Hi, I'm Katie Walker. I'm the CEO of Revitalist Lifestyle and Wellness. I'm also a CRNA, so I have an advanced degree in nursing anesthesia, and then soon to, actually in May 2022, we'll be graduating with my psychiatric nurse practitioner. So I'll have a dual role with anesthesia and psychiatry. And today I am joined by Matt Dolan. I'll let Matt introduce himself.
And I am Matt Dolan. I am also a CRNA, and I am also in the process of finishing a psychiatric nurse practitioner program, just like Katie. I serve as a provider with Revitalist and also the regional director.
So Matt and I are here to provide additional insight, kind of give some updates on the research, the new information that's coming to the surface with ketamine. So this is going to be geared more towards providers in the space that are looking at more of the, pharmacology, pathophysiology, different things like that. So we'll go through a presentation here, and Matt will actually help lead that. And then we'll do the presentation with the science piece. And as soon as I get there, we'll do the presentation with the science piece, and then we will, there you go. Can you see that?
Yes.
And then we will go through the different ways that we work with behavioral health hospitals, emergency rooms and such, to where we can kind of help share the burden, because we have a lot of interesting people with Revitalist that are psychiatrically based, primary care based, anesthesia based, behaviorally based with the therapist piece. So we're really an integrated team here to where we want to collaborate the most possible. So Matt, I'll let you take it off and I'll be your page flipper.
Great. So I want to talk a little bit about ketamine and how it works to serve to relieve and create a remission in the symptoms of anxiety, depression, PTSD, and some chronic pain. So we'll talk a little bit about the history of ketamine, the history of depression, pathophysiology of those disorders, and then how ketamine works to help those. So ketamine is historically an anesthesia drug, and those of us who have been anesthesia providers for a while have had extensive use with ketamine in the operating room and know it in that context. And so the use of ketamine as a treatment in the mental health context is a reasonably new concept for anesthesia providers. So ketamine's been around for a long time. We're comfortable with it in the OR, but learning to use it in a mental health context is new. So old dog, new tricks. Next, please.
There we go, sorry.
That's okay. So how do we get from the operating room and the use of ketamine in that context to mental health? So brief history of ketamine. 1956, phencyclidine, PCP, was first synthesized. When they started doing the human trials, they saw the profound hallucinations and other distasteful side effects. And so it rapidly became evident that that drug was not going to be able to be used. So basically, over the next few years, the scientists took the chemical structure of phencyclidine and altered it to minimize the untoward side effects, but to keep the pain control properties, and thus was born ketamine. So ketamine was first synthesized in 1962. It is a weak chemical cousin to PCP. It's about 1/10 the strength. Once that was synthesized and initial testing was done, FDA approval was achieved in 1970, and the first widespread use of ketamine was in Vietnam with battlefield surgeries. And I will circle back, we'll asterisk that point, and I'll circle back and talk about that here in a minute. So like with any, or I should say like with a lot of new drugs, once they're FDA approved, they start being used, then eventually they, number one, more research tends to be done because more and more people have access to it. But unfortunately, a secondary effect is that a lot of those drugs then have been through diversion and other means eventually filter down into the streets and start being used recreationally, which is what happened to ketamine within the next 10, 15 years after being FDA approved. So it becomes more and more popular for the use as a party drug. and then expands into more and more popularity, which then gets the attention of the media, which happened in the 90s. And so as more and more public stories were published about ketamine, then it started to take on a negative connotation. 1999, ketamine was finally scheduled by the DEA, and combination of that and the negative publicity resulted in the drop in the usage clinically of ketamine in healthcare settings.
So I'll add to this too. So ketamine is a non-narcotic, Schedule 3. And then like what Matt was saying, when it goes on the streets, because this is what we hear a lot of, is one, you hear it's a date rape drug. Two, you hear is a horse tranquilizer. And then three, you hear the term special K. So what I've noticed with the date rape aspect is those are pretty comprehensive. So they'll actually use ketamine. They'll use actually SSRIs, trazodone, a lot of your benzodiazepines. Those are all, and actually alcohol is the number one date rape drug there. So that's a common misconception actually in the space, but ketamine kind of gets that reputation a little bit there, even though it's, it's really more so a widespread issue. Horse tranquilizer aspect, that you do use ketamine a lot in veterinarian medicine. Reason being is because ketamine actually maintains your cardiac and your respiratory resistance. So when you are giving a little rodent some ketamine, or you're giving a tiger some ketamine, you can overdose or underdose on them, and you have a very wide safety index there. So when people say it's a horse tranquilizer, yes, it is, because of the safety piece. And that's why the World Health Organization said that it is on its list of essential medications for every country in the world because of its safety index. So it is a great medication to utilize in this capacity. I want to throw that in.
And what we tell patients too is, because invariably you get a lot of people come in and say, isn't that a horse tranquilizer, blah, blah, blah. And they mistakenly think that that ketamine was developed in the veterinary world and then came over to the human side of things. But I explained to patients that all mammals share many of the same receptors. And so drugs that work in the human world also work in the animal world and vice versa. So it definitely started on the human side and then went to the animal side for sure. So, and I'll sort of ad lib a little bit here. When the first MAO inhibitors, tofenil and imipramine, when the first MAO inhibitors were invented in the 1950s, and then we fast forward to the first SSRI, Prozac, was invented a few decades later, and then all the different variations thereof, we started gathering quite a bit of data. Once we had about 3 to 4 decades of data on traditional first and second generation antidepressants, then we were able to retrospectively analyze that data and started gathering some numbers as far as the efficacy with remission of symptoms long term. And the data shows, depending on which study or meta-analysis you look at, that traditional first and second generation antidepressants, the monoamine manipulators and modulators, have anywhere from a 35 to 40-something% efficacy rate, and that is defined by long-term remission of symptoms in a satisfactory manner without untoward side effects. And that is usually after people have cycled through a number of different drugs to find which one works for them consistently. Interestingly enough, the connection of ketamine and its antidepressant effects was first noticed in the late 1960s, but especially in Vietnam. Those dots first started being connected because they started seeing how patients that were treated with ketamine early on in their injury process ended up having less depression, and especially as far as Vietnam is concerned, less PTSD. When you look, and I've got a slide coming up here in the next few slides that shows the number of number of studies with ketamine and depression per year, you see it holds steady in the teens to low 20s until the late 90s and early 2000s. And then we see, boom, there you go. Then we see a huge explosion in the number of ketamine studies. And the reason for that is, like I said, once we gathered enough data on the traditional first and second generation antidepressants and got a pretty standardized efficacy rate, via retrospectively. Then researchers started looking at the efficacy rate for remission of symptoms with ketamine, which is reproducible longitudinally in the percentage range of 65 to 70% plus. So almost double the efficacy rate for remission of symptoms. And it's when we hit that realization standpoint, once we gathered enough data to compare traditional antidepressants to the antidepressant effect of ketamine and saw that ketamine is almost double the efficacy, that we see these number of studies explode. Next, please.
And I'll add a little bit to that, just a fun fact. When Yale accidentally discovered this with ketamine, they were actually working with rodents trying to make a fix for schizophrenia. So they're trying to induce rodents to make them go into a hallucinogenic state to where they would imitate schizophrenia. And they noticed that these rodents were actually becoming less depressed. So while ketamine is very much more popular to look at major depression, PTSD, anxiety, suicidality, and such, there's a wide array of studies that are out there that are looking at bipolar, mania, Parkinson's, Alzheimer's, and the data out there, it's pretty significant, like Matt was mentioning. So the way we look at it, it is a very comprehensive neurologic drug. And if it's a neurologic component, it seems that ketamine's doing something directly to show us that it can, increase the functionality with individuals. So lots of hope.
Yep. So just a very brief, quick history of depression. It's basically one of the largest, if not the largest, mental health just issues, period. Worldwide, over 300 million people, according to the World Health Organization, suffer from major depression. It's 2 to 3 times more prevalent in females than males. And the first written account of depression or depressive symptoms goes back to the 2nd millennium BCE. And like with anything, as our development, scientific development advanced, science advanced, understanding advanced, then, basically the understanding of depression and just mental health in general brought us forward to where we are today. But initially, like anything else, it was blamed on evil spirits or possession or any type of other things outside the body that were causing these issues. So obviously, as our understanding scientifically advanced, then the study of depression advanced as well. Really kind of hit its stride with the advent of study, and obviously everybody's familiar with Freud and Jung. But as our understanding advanced, then we moved from external causes to internal causes, and then finally into mental health as organic brain functions or malfunctions, whichever way you look at it. So now we're going to swing around to how does ketamine apply to the mental health world, and why does it produce such dramatic effects efficacy-wise? And the key to understanding that is understanding what goes wrong or what changes chronically with depression, anxiety, and PTSD and chronic pain. So there are multiple, obviously, lots of parts of the brain that have specific functions. In addition to those specific functions, most of the parts of the brain are also signal processing hubs. And so obviously, the processing of signals throughout the brain is a very complex, interwoven network with trillions of connections. Take-home message with that is, as with these chronic changes that happen with depression, anxiety, et cetera, as one or more parts of the brain start to work abnormally or ineffectively, then that not only affects that part of the brain, but it also affects any parts of the brain that are downstream signal transmission wise. So there are lots of different parts of the brain that deal with emotions, higher executive processing, coping with stress in a healthy way. The way we explain to patients is when we as human beings, when we deal with normal daily life stressors in a positive, constructive way, we use particular signal processing pathways in the brain. And those tend to affect or tend to stimulate activity in very specific parts of the brain. We talk a lot about the prefrontal cortex, sometimes dorsolateral, sometimes medial prefrontal cortex, but either way, prefrontal cortex is a biggie. Thalamus, hypothalamus as well. And the way that we explain to patients is that neurons, nerve cells in the brain are much like muscle cells in the sense of the more they're used, the more they're stimulated, the more electricity goes through them, the more the body realizes, hey, I need to make sure that these cells are robust, supple, and functioning well. And in the context of neurons, that term is neuroplasticity. It's the ability of the brain to respond to changes and needs based on electrical activity and use of those neurons. And in a normal functioning part of the brain, the more, like I said, the more electricity, the more those neurons are used, the more robust those neural connections are going to be maintained. And that all comes down to dendrites. Basic neural connection signal transmission is from dendrite to dendrite, or terminal axon to dendrite, rather. On each dendrite can be up to 10,000 spines, and these spines have a different morphology depending on the needed use for those spines and the number. And the morphology and the growth and the changing of these spines and the function are regulated by proteins. So the release of those proteins on an active basis, regular basis, is a huge part in maintaining the structure and number of these spines. And we explain to patients that with all these large number of spines on each dendrite, they're like signal towers. And so the signals are passed from nerve cell to nerve cell via these spines from dendrite to terminal axon and on, or well, actually terminal axon to dendrite and on down the path. So there are a multitude of neurochemicals that are involved in the process of maintaining these dendritic spine structure, health, and function. I'm just going to talk about a few of the biggies. BDNF, brain-derived neurotrophic factor, is one of the major ones. It is a major member of the nerve growth factor family. It is expressed very highly in the brain. It is regulated two main ways, one by genetic expression, and the other is activity-stimulated releases at the synapse, which goes back to, like I talked about, the neuroplasticity. The more you use it, the more it's going to build up. BDNF is a big player in helping maintain the normal dendrite number, spine integrity, and function. VEGF, vascular endothelial growth factor, plays a big role in hippocampus neurogenesis and neuroprotective response to stress. Levels of EGF are decreased in chronic stress, and it's postulated to be a factor in high comorbidity correlation with major depressive disorder and cardiovascular disease, heart attack, and stroke rates as well. Glutamate. Glutamate's going to be the main thing that we talk about. That's the main thing that most people talk about when they discuss ketamine. Glutamate is the major excitatory neurotransmitter in the brain. GABA, of course, is the major inhibitory neurotransmitter of the brain. They work kind of yin-yang. Actually, the role of GABA is the controlling factor. It inhibits the release of glutamate. So any drug that stimulates GABA function inhibits glutamate. So any benzos, lamictal, alcohol, any drug that stimulates or promotes or magnifies the action of GABA inhibits the release of glutamate. Glutamate is involved with controlling rapid and long-term synaptic plasticity through the release of proteins, which we're going to talk about here in just a minute. And its actions are mediated by inotropic receptors, which we're going to talk about as well, which are required for regulation of number of functional spine synapses. AMPA and NMDA are two biggies. mTORC, mammalian target of rapamycin complex, a protein kinase complex that regulates protein synthesis at synapses. One thing, let me just kind of pause here for a second and zoom the lens back. All these things that we're talking about, what is fascinating about ketamine, which will bring it kind of all back around to the final point. One of the things that's fascinating about ketamine is that the bottom line is it promotes the release of proteins that rebuilds neurons in the brain that atrophy with chronic diseases, chronic neurodegenerative diseases. And it does it through a multitude of different pathways, not just glutamate release. So it promotes these through a multitude of pathways. It's good enough.
Right.
All right, so let's just go ahead.
Well, I was going to say right. Everything that you're talking about, the reason we're talking about these is because they're all directly related to the way ketamine helps the whole brain to start, the plasticity aspect of to start, and that's the neat thing that we're trying to push across here.
Yeah. So on a cellular level, what happens in any type of cell, and really the best example of this is, muscle overuse. When the use of our muscle cells exceeds the aerobic capacity, then obviously we switch into anaerobic metabolism. And when that goes on for too long of a time, then we have a buildup of lactic acid, we hit lactic acidosis, which then causes cellular toxicity. The same type of thing happens with nerve cells in the brain, not in the context of lactic acidosis, but rather cellular toxicity that happens with overuse of cells, which causes a chronic inflammatory process. So in this context here on this slide, which says chronic stress, we're not talking about external stress. Now we're talking about cellular stress. So chronic cellular stress causes a decrease in BNF expression. Basically, it causes a chronic inflammatory process which inhibits the release of those proteins and normal nerve cell function. Hyperactive hypothalamic pituitary adrenal axis results in chronically elevated glucocorticoid levels and neurotoxicity with that, in addition to consistently elevated catecholamine levels, which worsens it as well. Like I said, I mean, everything on this slide just speaks to chronic inflammation that results in a neurotoxic event, which increases cellular apoptosis and decreases new cell growth. This slide just basically is a summation of the different parts, some selected different parts of the brain and what they do. And when they start to have chronic changes that happen with depression, anxiety, we see the behavioral manifestations that happen with those. So one of the interesting things that happens with depression is that the way I explain it to patients is when we are growing up, the normal process of going through childhood, early adulthood, and really on through most life stages, when we are faced with more and more life stressors, ideally we face those stressors and we develop coping skills that keep it's like a behavioral homeostasis mechanism. We develop coping skills that balance out the stresses of daily life. We all experience things in life that have profound emotional impacts that tend to outstrip our ability to cope with them at the time. And what our brain does as a protective factor is the brain tends to compartmentalize those strong emotions and kind of pack those away until we have more of a capability of dealing with them. So when that happens once in a while, that's great. The problem happens, there's a real fork in the road that happens when people start to, instead of facing stress and developing coping skills, they start to adopt more an avoidant behavior. When that happens, they use those parts of the brain that deal with stress and emotions in a healthy way less and less. And just like muscle cells, when they use those cells less and less, those cells start to atrophy. And postmortem studies have shown decrease in not only neuronal cell body size, but atrophy. Basically, here's the process that happens. First of all, the number of spines and the morphology changes. The number of spines reduce, and then the number of dendrites and the dendritic size reduces. Further on down that chronic pathway, the actual measurable, weighable mass of certain parts of the brain, specifically the prefrontal cortex, actually reduces. It's been shown in CT scans, functional MRI scans, and even in autopsies. So these are very real changes in the parts of the brain that allow us to cope with things in a healthy way.
And I'll add to that, Matt, something I was actually looking at last week was the children who actually grow up in a traumatic environment. They already show atrophy of the brain. Their brain size is actually different than children that grow up and where their needs are being met. So this is something, you know, that can also unfortunately start in the pediatric population. So one nice thing about us too is, you know, is we do have our Revitalist, we have our BLS, of course, but we also have our ACLS, which is your advanced cardiovascular life support. And we also have our PAL certification, which is your pediatric advanced life support. Fortunately, Matt's also an instructor. So we have all these things. And then, you know, the youngest we've had is 12 so far. 12 is the youngest, 90 is the oldest. The teens, they're very plastic, right? They're still trying to figure out who they are. So they're pretty moldable. And if you put them with the right support systems, give them the right structure, the right guidance, they really will do well. We've had some children come in that will have, you know, suicidal and homicidal ideations, sometimes coexisting, and we'll get them back into school. You know, and two, what we do is we try to support the whole family unit to where a therapist will actually speak with the parents as well to try to show these are the best learning styles. These are the best communication aspects that your child will hear. So really it's, you know, it's working together with all of these to try to prevent, you know, long-term bad.
Yep. This slide is just a summation kind of the brain changes that happens. The red arrows represent stress that happens and eventually major depressive disorder. ADT stands for antidepressant therapy. Traditionally, antidepressant therapy does increase synaptogenesis and neuroplasticity, but it does it in a much slower process. But anyway, so this basically just sums up kind of most of what we've been talking about. I'm going to hit the amygdala at the bottom. We're going to hit here in just a minute when we talk about anxiety and PTSD. All right, so there are a couple of good slides. This is a very highly referenced study by Dolan that came out in 2014. This particular one shows the changes in the number of spines on dendrites that happens. On the left, obviously, is control. On the right, stress. With this particular study, rats were placed in I believe it was for 20 minutes of stress at a time, and I think it was swimming stress. So 20 minutes at a time, 2 to 3 times a day for 2 to 3 weeks. So this is a very short-term study. And even in that short-term, low-stress environment, you can see the profound changes that happen to the number of spines under stress. So with the medial prefrontal cortex function, when that starts to decrease because of the neuronal atrophy, then we start to see some of the behavioral manifestations that we see in depressed patients. They move slower, they think slower. A lot of them say, I feel like I can't, you know, I can't think straight. My brain's in a fog. And we're going to talk about the amygdala gain of function here in just a second. So, all right. So a lot of other things that happen. So like I said, you know, going back to everything being interconnected, and when one or more parts start to work not as efficiently, it affects a lot of others downstream. So you start to see kind of a domino effect happen when the signal transmission starts to deregulate between processing hubs. So disruption between the prefrontal cortex and amygdala and the ventral striatum start to decrease in the motivation reward system, which is why we start to see the changes in eating, sleeping, libido, anything that provides us with the feel goods starts to get disrupted, and that leads to the anhedonia that we see with patients frequently. This is a slide that shows the coolness is in glutamate activity in the brain. So with depressed patients, a lot less glutamate expression. So the cooler colors on the left and on the right, obviously the hotter colors are more activity by glutamate expression. All right, just another slide that shows the difference. It's the same two as far as the dendrites on the right. The two slides on the left show the entire nerve cell and the changes that happen just grossly, not even just in spines, but just grossly the nerve cell in general, with the number of dendrites. Yep. All right, so the take-home message with regards to depression is when these changes of the brain start to happen, patients cannot process things in a healthy way nearly as efficiently. They have an increased propensity for cycling negative emotions and negative thoughts. Their higher executive functioning decreases. They can't prioritize, they can't multitask. They can't sustain clear and cogent thought patterns, and they have a very difficult time escaping negative thought patterns, which leads to inability to achieve behavior extinction or thought or memory extinction. So bottom line is this is all a chronic vicious process that's right, and which starts to, like I said, the domino effect and worsening the symptoms. Anxiety is very similar, but in some ways the reverse happens. So obviously our amygdala is the part of the brain that a lot of people talk about with regards to the survival mechanism, and it's a prehistoric survival mechanism. It's hardwired into our brains. And basically, whenever we sense a threat of any kind, our amygdala is stimulated, and through a variety of chemical reactions, a release of catecholamines, our adrenaline, epinephrine, and cortisol released, all in the purpose of keeping us alive and not being squished by a big T-Rex, which is great, except for chronically, again, going back to the muscle cell analogy, anytime that a part of the body is, the cells in the brain are used a lot, they are stimulated, and the brain says, hey, I need to make sure that this part is robust and grows. So with patients that have chronic anxiety, the amygdala is stimulated more so than it normally is on a chronic basis. And what happens with that is the opposite. It happens with depression. The amygdala actually becomes hypertrophied. It grows larger than normal. It also becomes hypersensitive and hyperreactive. And so instead of the amygdala firing off the threat signal, the fight or flight, when a car comes screeching around the corner and we jump out of the way, the car goes on down the road and our heart rate returns back to normal and our palms dry out and all that stuff. That's a normal function. With people that have generalized anxiety disorder or chronic anxiety, that amygdala is firing all the time. And so instead of them returning to a baseline of 0, these patients have basically live at a +1, +2, +3 level. So their amygdala is constantly being stimulated, constantly firing off, hey, I'm threat all the time. So in a nutshell, that is what happens with chronic anxiety. And it ends up being, just like depression, it ends up being a vicious cycle. The more threats that are perceived, whether conscious or subconscious, whether emotional, physical, conditioned threat response, basically the entire threat response system becomes hyperactive and hyper-responsive and hypertrophied. This is a big, another big player in the anxiety and especially the PTSD is the hippocampus. And one of the major functions of the hippocampus is formation of memories. Not only formation of new memories, but memory consolidation over time, memory extinction. And it is the process by which, the example I give to patients is, we've all had relationships that got kind of stale and the negative outweighed the positive, and so we moved on. And the phenomenon that happens over time is we tend to look back and remember only the good things. That's a normal function of the hippocampus, is to reconsolidate those memories and only kind of remember the good stuff. Another thing that the hippocampus does naturally is it replaces old memories, old negative memories. It allows us to replace old negative memories with new ones, with more positive ones. With chronic anxiety and PTSD, the function of the hippocampus is altered in the sense of it does not allow people to form new memories to replace the old negative ones. And so people tend to be stuck in the same old negative memories, which cycle over and over and over again, which is a hallmark sign of PTSD and one of the hallmark symptoms of PTSD. So it's not only the amygdala that malfunctions with anxiety and PTSD, it is also hippocampus. And, you know, the function of those two, the amygdala serves to keep people on edge all the time. The hippocampus does not allow them to eventually, you know, allow for memory extinction and replacement with better things, better memories. So they end up just recycling the same old negative stuff, which then triggers the amygdala, and on it goes. So ketamine mechanism of action for depression, anxiety, and PTSD. Ketamine, we're going to talk about mainly glutamate, but ketamine actually hits a large number of receptors, including dopamine, norepinephrine, stimulates serotonin neurons and receptors. Ketamine inhibits the action of GSK3, which is a glycine synthase kinase 3, and it's really GSK3 beta, but we just abbreviate GSK3. GSK3 inhibits neurogenesis and increases apoptosis. So if GSK3 is inhibited, apoptosis rate goes down, which means that cells live longer, the neurons live longer, and there's an increase in the neurogenesis. Sorry. So the main function or the main mechanism of action of ketamine that people talk about is the blockage of the NMDA receptors and methyl D-aspartate receptors. So ketamine is a non-selective NMDA antagonist. When NMDA receptors, they are voltage regulated receptors. When they are open and ketamine is in the system, ketamine actually binds to what is called the PCP receptor. The PCP receptor is mid NMDA receptor. And so the ketamine actually locks the NMDA receptors open when it binds to the PCP receptor in them. So when that happens on those NMDA receptors on GABA cells, GABA releasing cells, then GABA is inhibited. When GABA is inhibited, more glutamate is allowed to be expressed. And that results in what we call a glutamate burst. And when it happens, those transiently higher levels of glutamate result in activation of AMPA receptors, results in increase in the brain-derived neurotrophic factor, which then activates the tropomyosin B or TRAC-B receptors. And it also activates mTORC, the mammalian target of rapamycin complex signaling, which then releases more BDNF, which then releases more proteins, and those proteins go to stimulate the growth and change in morphology of the spines on the dendrites.
And I'll add a little bit here too, Matt. There's a lot of theories here that are, the neat thing about this is where it's a lot of evidence-based data with ketamine. So there were some fears with ketamine where it did, increase your glutamate release, that it could cause a glutamate storm. Also, there was fears here too, where it works with serotonin, that it could cause a serotonin crisis. And they're actually seeing that on both of these cases, that it's actually causing more autoregulation. So it may give a boost to glutamate, may give a boost to serotonin, but it's actually causing the whole system to autoregulate. Same with people who have, so at anesthesia, we give a very big dose of ketamine when we use it for a true general anesthetic. Which has a lot of side effects. But if you look up ketamine with the FDA approval that it's had since 1970, it will say that actually liver dysfunction is a contraindication. There's a recent study that just came out by a psychedelic company looking at ketamine with people who have chronic substance use disorders with alcohol, and who actually had elevated LFTs. And it actually showed that the ketamine that they received over a 6-month period, their LFTs were actually decreased too. So there's a lot of theories out there that we all should consider, but there's a lot of data out there that will support that. So no, we've not ever seen a glutamate storm, knock on wood, right? We've done maybe 11, 12,000 infusions. So the probability would be very small with that. So glutamate storm, serotonin crisis, we do know what to look for should those situations present themselves, but we've not seen those. So those are just all theories. But what we do see time and time again is autoregulation. And we see autoregulation of anxiety symptoms, PTSD, depression. A lot of those things seem to just go back towards the middle.
Yeah, and this slide is a good summation, basically, of the process that starts. And I really like this slide because it's numbered. Basically, what happens: ketamine binds to the MDA receptor on the GABA neuron that inhibits the release of GABA, which allows for the release of more glutamate, which is represented by the blue dots. So the glutamate is released. It binds to the AMPA receptors, which in turn allow for the release of BDNF, which then binds to TrkB receptor, tropomyosin KB receptors, which then activates mTOR, and on and on it goes. So basically, like I said, ketamine is a multi-system. It initiates a multi chemical reaction, chemical process that results in the release of proteins that rebuild those neurons. So this is, we do have glutamate throughout our body, but it is intensely concentrated in the brain, which is why we see the profound responses in the brain with mood disorders with ketamine. So this slide just shows basically with an MRI, with functional MRI baseline, the hotter areas on that mid-level set of images. The red and yellow is decreased activity of glutamate. And so when we get down to the bottom, the cooler, the green, the yellow show an increased level. It's sort of counterintuitive, but that's the way that they coded the colors here on this slide. All right, so all those proteins are released, which allow for the spines on the dendrites to build back up, increases the dendritic number, structural integrity, and spine growth, which therefore increases the available synaptic surface area, which then increases synaptic transmission, medial prefrontal cortex and hippocampus, which leads to, which is what Katie was talking about, a homeostatic balancing and return of normal function to the medial, to prefrontal cortex in general, not just medial, and hippocampus functioning, which then results in the remission of symptoms that we see with depression, anxiety, and PTSD. So it really is a rebuilding of those neurons, and it is in reestablishing of the normal or more normal synaptic transmission that reestablishes the homeostasis that we see, which is what Katie was referencing with that. Just another picture showing the changes in the number of, this is just with one infusion of ketamine, this particular study, the number of changes, the changes in the number of spines on a dendrite.
This is my favorite slide ever, because I think it's so simple. But I'll tell you, I was looking at the dendrites personally, so the arrows there, your dendrites, of course, and I was looking at, how they seem, so negative up top versus you can kind of see the vascularity to them, is much better after the one ketamine. But one thing that I didn't see for such a long period of time was the actual pathway and how negative the path looks on the top compared to the bottom. So it does show you, so ketamine does have anti-inflammatory properties as well. So, is it causing all of this in such a short period of time, which has given us the results that we love seeing? So yeah, sorry, I get excited about this slide.
So pain is its own animal, is with regards, well, it's its own animal, period. But basically, we'll talk about kind of how ketamine works to alleviate symptoms of chronic pain and CRPS, which is complex regional pain syndrome. So it's important to understand the normal pain functioning, the circuitry. Normally speaking, and I'm just going to ad lib here through these slides. Yep. Normally speaking, let's say, and I'll just use the picture that was on the slide previous where the person banged their toe. All right. Let's say we bang our toe. That banging of our toe damages cells in our toe, and the damage of those cells releases chemicals that signals to the body, hey, we've got cellular damage here. So the signals, among the signals that are sent are pain signals. So they're sent from the point of injury, the cellular injury, up the peripheral nerves, and then those peripheral nerves join in the, as far as the pain is concerned, dorsolateral dorsolateral horn of the spinal cord. So there's a signal processing hub where the peripheral nerves meet the spinal cord. The impulses are sent up to the brainstem, which is another signal processing hub. From the brainstem to the midbrain, which is another processing hub, and then to the cortex, where those signals are defined as what they are. And then efferent signals are sent from the cortex on down through the same processing hubs. So in a normal functioning pain process, as long as those cells are damaged, those signals will be continued to sent up to the brain, and then the responsive signals sent down. Normally speaking, when that initial insult is healed or stops, then the signals are stopped from being sent upstream, and then the response signals obviously are stopped downstream. This is all done through, I reference multiple processing hubs, both peripheral nerve to spinal cord to brainstem, brainstem to midbrain, and midbrain to cortex. At any point along those processing hubs, so the signal processing is achieved through a multitude of neurotransmitters and neuromodulators. The class ones, dopamine, serotonin, norepinephrine, but also estrogen. It's a large number of chemicals that mediate pain signals that go up and down. So that's what happens. Oh, go ahead. Sorry.
Well, I was going to say, so like with this, so CRPS is, looking at behavioral health. Like a lot of people may not even know what CRPS is. And I'll tell you, a lot of medical providers don't even know what CRPS is. And then also Matt and I come from an anesthesia background. CRPS is still not widely known, even anesthesia experts who are pain experts. But so basically you got CRPS 1 and 2. It seems right now that orthopedic surgeons are more so the ones that are diagnosing CRPS and neurologists. But used to CRPS was called RSD. But the context that we see pain with ketamine is, you can label it as RSD, CRPS 1 or 2. But it seems that most of the individuals will have a pre-existing or coexisting diagnosis with fibromyalgia, neuropathic pain. They'll have interstitial cystitis. And a lot of those individuals have the coexisting mood symptoms that also go along with that. So we do have the option not only to look at their mood, but also look at their pain, because they are directly related. Exactly what Matt was saying is, there can be a hiccup in any of these, and we've got all the same, neurotransmitters here that are coexisting. And we don't know why some people's may be pain versus mood. We're still trying to figure that out. But one thing that I have noticed with individuals who have these symptoms, they may have pain in their right hand, or like what Matt was saying, when you hit your toe, say you hit your toe on your right side, if it's of a neurologic presentation of pain, then what may happen is it may go on the right side of your foot, and it will may be duplicated to the left side of your foot. And then it will go up to the major joints. So you can actually talk to your patients about pain and, and ask them, they'll be like, oh, my right hand's killing me. And you can say, well, do you ever get it on your left hand too? Which makes zero sense to true pain insults. But if they say yes, then you got an insult or a defect in the way that your cells are communicating internally, which ketamine helps with that as well. So
yeah, and so this slide is just an illustration of what we just went through as far as normal signal pathway up and down. What's interesting is on the right in that blue box, actually, let's go to the red box on the left first. Traditional pain medications that we use, opioids, ibuprofen, acetaminophen, lidocaine, they all work to decrease pain by inhibiting the ascending pain signal. On the right, in the blue box, the gabapentinoids, sodium channel agents, and tricyclics and SNRIs, cannabinoids, ketamine, they work to facilitate decreasing pain signals by modulating the descending pain signals.
And looking at this too, so there's a lot of question on addiction to ketamine with pain, but actually ketamine does the reverse, right? So if you're on opioids, it increases your sensitivity to where you actually create more receptors needing more opioids to have the same outcome. Ketamine actually causes central desensitization to where it lowers the amount of receptors. So people who are even on opioids, should they get a ketamine infusion, their sensitivity is going to decrease to where, or it's going to increase, I guess, to where they can actually take less drug to get the same effect. So it kind of detoxes them. And I don't know if you've seen stuff with ketamine and detox, but that's very common there as well.
All right. So
induce detox, not cause detox.
yeah. So what do we see with chronic pain issues? So, we talked about the normal signal path processing up and down, and when the cells heal, then everything stops. But what do we have when we have these patients that have chronic pain? Well, somewhere, they may have an initial injury, legitimate injury, cellular damage, whatever, in which starts that, pain is a chemical process. So it's like Katie talked about, a lot of times what happens with these chronic pain CRPS are altered cellular function somewhere along the way for whatever reason. Crosstalk between neurons, upregulation of NMDA receptors in the dorsal horn, inflammation, which causes peripheral sensitization, which then results in sustained signaling in the absence of noxious stimulus. Which means, and the way I explain this to patients is, when the stub toe heals, ideally all the signals stop, right? But what can happen through a multitude of factors is at any point in those signal processing hubs, whether peripheral nerve to initial junction at the spinal cord, brainstem, brainstem to midbrain, or to the cortex, anywhere along those points where the signals are processed and sent, cells can start to work abnormally and keep sending pain signals even though the initial injury has healed. And when that happens, that sets a patient up for chronic pain. That's why patients tend to have, and phantom pain is one version of that. It's one flavor of that, but it's can be a multitude of different manifestations, not just a specific limb. And this is what Katie was referencing. You can have an initial injury in one part of the body and eventually have other parts of the body which are not necessarily directly connected be affected by that. And that all has to do with those cellular or signal processing hubs malfunctioning. And it can happen at any one or a multitude of those processing hubs.
And this too, I think, Matt, make a big, we should all consider this as well, is, individuals who suffer with addictions. This is a big thing here too, because if you ever talk to someone who is chronically on, some type of opioid consumption, they become so sensitive to everything. Like their pain is so bad. So, one neat thing with ketamine too is it can look at this and it can, decrease that sensitization, but then also it can help to address kind of the underlying aspects that are causing the negative coping mechanisms as well. So that's why we believe future occurrences with addiction aspects, it's going to be a very, very big thing to consider.
Yeah, and actually piggybacking onto that, the lateral habenula is a part of the brain that is really gaining a lot of attention research-wise as far as addiction, because it's one of the big parts of the brain has to do with a reward center, part of the brain. And so ketamine definitely works on that as well. And so there have been a multitude of studies. One particular researcher, Krupitsky out of Russia, has published numerous studies on the use of ketamine for the treatment of heroin addiction, alcohol addiction, and also cocaine. So yeah, kind of getting back to what Katie was saying with addiction, big time. All right, so anyway, this slide just kind of shows what can happen, central sensitization. So even if you have, so I just kind of talked about the chronic pain after the initial insult has healed, but sensitization, central sensitization happens when at any point, just to use a number, let's say that the pain level going up your peripheral nerve is a 2. With central sensitization, once it hits a processing hub, for whatever reason, that processing hub or multiple hubs magnify that. So instead of the initial injury or pain level signal being a 2, those processing hubs magnify that to a 6 or a 7. So by the time it reaches the brain, it is actually a much more magnified or amplified pain signal, which is one of the big things that happens when those patients that have allodynia, where they're just a light touch on the skin is just excruciating to them. And that is a great example of central sensitization, how that normal sensations are magnified way beyond their initial signal impulse.
And the brain duplicates what it knows. I mean, that's the thing, what Matt was saying, if people get to the point to where they can't even wear clothes that aren't satin to the touch or free flowing because their skin hurts, their skin crawls, the wind hurts it, it burns, it stings. If you talk to them about those things, you can actually chronologically step back when their pain started, because pain does not start like that. The brain duplicates what it knows because it expects some type of threat. And then it eventually turns into that. So it could be just a sprained ankle. And unfortunately, we're seeing this a lot with teenagers, female teenagers, believe it or not, to where for some reason, unfortunately, some people are thinking it's a good idea to put pain stimulators in these children instead of looking at ketamine first. But ketamine is actually helping, if it's a sprained ankle, yes, it's a 13-year-old, I understand that, but sprained ankle to where it's not to where it was just pressure. And then it turns into pain and it's burning and it's stinging. Now it's all the way up my leg. Now it's in my left hip. Now it's in my right shoulder. And the people that are experiencing this, they don't understand it, but they follow a very specific pattern. So if we can work on the central sensitization aspect, from the neurologic pathophysiologic aspect, and then also from the behavioral aspect, trying to understand the pattern as to why the brain thought this would be a good idea to duplicate this negative coping mechanism pathway, which is equaling torture to these people over time, which may cause addiction and everything like that, then we're able to break that cycle kind of at the core root. Let me skip on here.
Yeah, that's fine.
So more pictures on how we're starting to understand this complex procedure or complex presentation. And that's why it's called complex and regional.
So one of the things I do want to touch on real quick, so the slides have shown a couple things. One is the magnification of true signals being sent up through those processing hubs. The other is what we talked about when we said the initial injury or the insult has healed, but for whatever reason, those signal processing hubs keep sending signals that there's damage and therefore pain. It's important to understand that it can happen. So these signal processing hubs can send these aberrant signals anywhere, even in the midbrain or even in the cortex. And so that's when we're talking about patients with fibromyalgia. And I know that that's people tend to be very Coke or Pepsi about fibromyalgia. There are those that think it's just a bunch of garbage and those that believe wholeheartedly. And, if you understand the process that happens with central sensitization, that these pain processing hubs, even in the brain, can start to just keep sending their own signals. It's very similar to what happens with atrial fibrillation or ventricle fibrillation. The normal conduction pathway is aberrant, and you've got these cells that are sort of keep firing on their own in an aberrant process. And that is a semi-good analogy to what happens with some of these chronic pain processes as well. So CRPS, we touched on. CRPS almost always starts with what it would otherwise be a very, very benign soft tissue injury. It doesn't even have to be a major thing. It can be a sprained ankle. You could bang your arm against a table. It doesn't have to be a profound injury. But for whatever reason, what happens with CRPS is that it develops a localized autonomic dysregulation, and that manifests with intermittent swelling. It's profound vasodilation and hypersensitization of the neurons in that area. So you end up having, and it's centrally mediated, but it's locally manifested, if that makes any sense. And it's basically the take-home message with CRPS is autonomic dysregulation in a localized peripheral part of the body.
Yep. And it can be core, like Matt just said, it can be core, it can be peripheral. With the peripheral aspect, it usually starts in the smaller bones. So it'll be in your wrists or your ankles. With females, especially that have had female trauma, whether that be miscarriages, endometriosis, if they've been raped, anything like that. Those can be core lower stomach issues that we've kind of seen. And those are, the core is a little bit more resistant than the peripherals, but that's something that, can be easily addressed with this. And we can kind of see the localization aspect, even though what Matt just said, it's centrally located.
Yep. So how ketamine works for chronic pain. In a nutshell, what ketamine does, and if you remember, we talked about how ketamine actually has activity on a large number of receptors. We talk about NMDA receptor with regards to mood and anxiety and all that. But ketamine actually binds to a large number of receptors. And what it does, our protocol, which we're going to talk about here in a minute, our protocol for chronic pain involves a very intense back-to-back day infusion process. And the reason for that is we want the ketamine to bind and saturate those receptors, and essentially the therapeutic effect of that is to break that cycle of aberrant pain signal processing that happens in the body. In the analogy I use with that, getting back to the AFib and the VFib, is it's when we use a defibrillator to we use a defibrillator on AFib and VFib to stop that electrical process and allow the normal electrical conduction pathways to take back in. Same thing happens when we use ketamine as a treatment for chronic pain. We want to saturate those receptors. We want to inhibit those aberrant signals, both up and down, but primarily down, which is where the primary mechanism of action ketamine has on pain. But saturates those receptors, break that aberrant pain signal cycling, and allow for the return of a more normal signal processing up and down the spinal cord and in the brain as well. All right, so this basically, this slide just talks about a couple studies that have been done looking at ketamine augmentation for chronic pain patients. And it's done, a lot of these studies are done in cancer patients because those obviously there's a lot of them, and they quantifiable and qualifiable pretty easily. But anyway, so like Katie was talking about, the use of ketamine it not only augments the use of opioids, but it also reduces the overall opioid need. So it's not just another type of pain medication that augments opioids. It's not just another hydrocodone and acetaminophen. It actually works to decrease the amount of pain signaling, which then really results in less need for opiates.
And if utilized too in the correct way, it will almost act as an anti-abuse piece for individuals that are taking or smoking or having different substances come into their system that they may know are of negative benefit to them, but it's causing a positive reward. So like Matt was talking about earlier, the lateral habenula, there's a default mode network in there. It resets the default mode network to where a negative pattern may cause a negative reaction. So say if I am addicted to oxycodones or hydrocodones or whatever else, and I know that it's bad for me and I get ketamine, I could actually get nauseated before I take them, because it's the psychological effect that ketamine resets that default mode network. So if anything, it's something we should lean towards with this. We do IV infusions in-house. We don't necessarily believe in sending anything home with individuals because of the complexity of all of these things. Matt and I are anesthesia providers. We understand medications and drugs very, very well, but also the addiction rate of anesthesia providers is also very high. So we understand, taking a substance home to a complex situation, even if you don't have, 10 years of schooling like Matt and myself have, can create a situation that may not always be beneficial for the consumer. So that's why we have these clinics where we do the IV infusions in-house. And we work with these individuals to try to help support in different ways, whether that be helping to support with the neurotransmitters outside of, or helping with anti-inflammatory diets, anything like that. But yeah, so if you're looking at ketamine for addiction and pain, I would strongly encourage people to look at that at an in-house clinic modality.
All right. So basically, kind of sum everything up. The brain changes that happen mood-wise, depression, anxiety, PTSD, and even chronic pain, although they're, like I said, they're two different systems, but the changes that happen in the body are very real. And so, we tend to, especially with mental health, we look at behaviors and we see people that we see the manifestations of these brain changes, but we don't necessarily identify them as brain changes. We just see them as behavioral changes. But the brain changes that happen with chronic anxiety, PTSD, pain are very, very real. And once those brain changes happen, it's as unrealistic to expect these patients to just snap out of it as it would be to expect somebody who hasn't been working out to go back in the gym and lift 500 pounds. It ain't going to happen. So take-home messages, these brain changes are very real in these chronic conditions. And the things that we see, the behavioral changes that we see, are just manifestations of the pathophysiological and neurophysiological changes that happen with these.
Yep. And I'll say down here, Matt, where you've got it hyphenated or with the brain fog here is one thing with COVID, especially that we've noticed is, a lot of people say they feel like they're in a brain fog. And there are studies that have came out that state that COVID does cause inflammation of all of your cerebral. What am I thinking about? Your 12. Help me, Matt.
Yeah, the cranial nerve.
Your 12 cranial nerves, yeah. But it does cause inflammation of all 12 of those. So that could be the brain fog aspect too. And then, it causes tinnitus and all these other things. So there's something that's correlating, across the board here. And two, unfortunately, we've seen a lot of increased deaths with COVID, with people who have coexisting mental health. And they're seeing now the thought process is starting to evolve a little bit to where the blood-brain barrier with mental health may be more porous, which is causing cytokines to kind of go back and forth, which is actually causing, people to acutely die, more quickly, or be of a higher acuity and then die. So one neat thing too, while we're talking about ketamine's kind of the godfather of all these psychedelics that are coming to fruition. And that's the mechanism of action that they're trying to replicate. So with that piece too, they're seeing that psychedelics in the rodent population are actually showing improvement of the lining of the brain, which hopefully would decrease that cytokine, activity going back and forth. So that's something too to, also be aware of.
All right, so like we discussed, the traditional monoamine-based antidepressant approaches, depending on which study you look at, anywhere from the 30s to 40s as far as success rate. And by success, again, we mean like long-term remission of symptoms with acceptable side effects. And you look at the ketamine infusions, reproducible longitudinally, around a 65 to 75-ish% success rate in remission of symptoms. So very profound difference. And then Katie likes that slide.
Oh, I did.
This is likes the colors.
I like the colors. Oh, I like these colors.
And that one too.
This is the way I contributed to Matt's presentation. I said in pretty fiction.
So the rest of the slides, Katie, are just the treatment protocols and then our different, athletes and vets and all that stuff. Do you want to kind of talk about this?
Yeah, I can go over that real quick. So the referral piece with this, so individuals. So Matt, hopefully you know more about ketamine now than you did and the pathophysiology that correlates with it. But with ketamine aspects of we're almost to the point now, just because the death rate is so high with losing individuals with suicide and overdoses and going to the ERs and going inpatients, it's safer to refer a client and have them sit with someone who does a psychosocial evaluation than to not. So you don't necessarily have to understand 100% of our protocols. We sit with these individuals, do the psychosocial evaluation, or they'll sit with a medical provider, do a 60-minute consult to where they can actually go through these different pieces, because our internal team are pretty well educated, especially down to the great details of understanding of the pathophysiology, the pharmacology, pharmacodynamics, all those things. So anyone can come for these referrals that you would like to send. We'd be happy to evaluate them and then let you know one way or the other. Also, our providers are very good with collaborating with others. So we're all about trying to put the person first and then helping to advocate for the system around. So if you have a person that you want to see, you don't have to worry, or want us to see, you don't necessarily have to worry about sending them over and them being lost or them being gone. So the anesthesia aspect and the nursing aspect that we have in the background with the company is we're used to working with individuals all around us. So we worked with every specialty there possibly is. We do also have, we have an ER physician who's also one of the leads of the clinics who also is very well aware of how to work with those individuals around them. So the goal of this is not to take anyone's patients by any means, but to help to collaborate, help to take the burden off so we can help optimize the system so we're more effective with helping individuals. So treatment protocols here. Like Matt said, we do offer 3 different infusions. We do a 40-minute for depression or for mood. We do a 2-hour that has coexisting mood and pain. And then we also offer a 4-hour, which is pain. So the mood can be typically what we'll see is we'll see 5 coexisting things. Even though they may have a primary diagnosis, we'll see some differential diagnoses on there or secondary diagnoses to where it may be depression, anxiety, PTSD, suicidality. A lot of times these individuals also have insomnia. And we do scales prior to each to try to see how they're progressing, to try to make this very objective, because individuals who come to us feel lost. They feel very subjective and they're looking for something to start guiding them again. So that's what we really work on, is trying to quantify the data that they give us so we can kind of help them to understand their patterns. Once they can understand their patterns, then they can actually look to help break the cycle instead of having the cycle, keep reproducing itself. So with the infusions, the studies out there state, is it disassociation? Is it the dose? So we typically will do 0.5 mg per kg. And then we look at their disassociation level and we focus on trying to make it to a mild disassociation, but we try to make the person comfortable. And then we encourage everyone to sit with a therapist. We understand that not everyone's going to be comfortable with that, literally, to where we really try to still encourage that, but we don't force that upon anyone, but we want to help support the system outside of it. So some individuals may come to us, say it may be a first responder, and they just don't feel comfortable with sitting with somebody. We will still help them, monitor them. We'll encourage them to be, even sit with a therapist afterwards or before, or do a session, different pieces like that. But we really try to look comprehensive at each individual. So this talks about the mood and pain, like I just mentioned, with the 2 hours. Here's the chronic pain. Really with these individuals really need a very big evaluation process, because Matt has it right here, it's very intense. It is very intense. It's 5 4-hour infusions in a week's time. And what you're trying to do is you're trying to break that whole cycle of pain, right? And he was talking about the, kind of the miscommunication between the pathways, but you've got your C fibers and your beta fibers and your alpha fibers, and you can kind of see the progression of that. To where the goal is for us to try to break that communication at the alpha level in order to try to break the cycle of pain. So we've had individuals who have came to us after they begged a surgeon to cut their leg off after they've had 13 surgeries, and they went 2 years with completely pain-free. So we've gotten individuals off of their dilaudid, their gabapentins, their Lamictal, their Lyrica. Like there's a lot of different combinations that we've seen. And the neat thing is, we're able to decrease this to where we can actually find things that work very effectively. So this is talking about the therapy integration that we use. We have a wonderful base of therapists here. And we also, so we're kind of implementing the medical, the behavioral, and the psychiatric piece to where we can optimize the system. And that's something that we're working on, because we're seeing the direct correlation here to where if we look at it specifically, we're able to best help these individuals, to where Matt and I commonly will talk to these people on the phone, and they'll cry on the phone because they say they've never been listened to or understood as well as what we can understand them, which is really exciting for us because we've been involved in so many ketamine infusions. We can see the coexisting aspects of the behavioral, the medical, and the psychiatric, which makes us have the ability to look at these individuals, through a somewhat slight different lens, which can be complementary to all 3 systems. And then, so we do look at underserved. So we do have athletes. That's a big piece there. We have our veterans. We do have the VA can actually send us clients to all 10 of our locations now. And that needs to come through their psychiatric providers as well with the referral aspects. But we are deemed experts in the VA system with the community care aspects. So with that piece too, talking about service lines that we offer, we do offer the three primary for mental health would be Spravato, TMS, and ketamine. The VA will typically send us more so ketamine and TMS, but we also can do Spravato should we need to do Spravato. So looking at behavioral health, if it's a hospital that wants to provide Spravato in-house, that's something that we can continue to provide outside of in the outpatient community. So it could be a referral process. Once you discharge those individuals, you can refer them out to us, and we can have that continuity of care, and then we can send a summary of care letter back to the provider that discharged them to us, so we can make sure everybody's on the same page. Also, with the ketamine aspects, we do have the ability. So Matt and myself, the other anesthesia providers in the company, we've all sedated people for ECT therapy as well. So we have that ability to do that if necessary. We also have the ability to come in-house and do ketamine infusions if need be. So what we like to do, what we see, and what Matt kind of spoke about was, you can do one infusion, you'll break the cycle. There's just a lot more that comes out. So one thing that we've talked to sometimes, with professionals in the behavioral health world is if there's a need to come to the hospital to do a ketamine infusion in-house, that's something that we can provide. And then we could transfer them out once they're able to be discharged, once they're more stable. We can transfer them out to the clinics and help with that continuity of care and continue with the ketamine infusions, the therapy. We also have, in the state of Tennessee specifically, we have the intensive outpatient programs for the civilian population, but we do have the ability to do the intensive outpatient programs for the veteran population as well. Through the VA, they can refer veterans to us to where they can have a support group as well. So looking at these pieces, like I said earlier, ketamine, typically it's treatment resistant, right? So we'll say you need to fail at least 2. Those are our personal protocols. And, we look at that more so from a pharmacologic level, but then 2, if someone does have coexisting suicidality, that is someone that you should send sooner than later, because it does help to break that much more quickly. So even if they've just failed 1, or they've been inpatient, or there's something going on where they do have the coexisting mood and the chronic suicidality, we will look at those individuals much more quickly and try to optimize them, get them in to where we can really start to focus on that, just because they are such a high risk at ending their life or attempting to. TMS, we provide that, and we actually have that at 5 of our locations. So that's in Johnson City, Chattanooga, Knoxville, Tennessee. We also have it in Raleigh, North Carolina, and then Louisville, Kentucky. With TMS, we do provide TMS for pain as well. That's a cash basis. We actually charge $175 per session there. It's usually 10 sessions. They can drive to and from with TMS, which is different than ketamine. Ketamine, we're fine if they drive to us because they've not been medically altered, but they need to have a driver home. So TMS does give an option for someone if they don't have a driver to help them to and from. And then also TMS, for it to be approved by insurance, they need to have major depressive disorder and have documentation of failed 4 antidepressants. That's how insurance will cover that. So though TMS is FDA approved for OCD and major depressive disorder, at this time, insurance does not cover OCD. They do cover major depressive disorder if they have failed 4 antidepressants. And they always need a prior approval for that. So Spravato is the S-ketamine. So it's the left isomer of the racemic ketamine. And with that Spravato, they really want them to have failed at least 2 antidepressants. Each insurance company is different. So some want them to have failed 2, but they want them to be maxed out on dose. Some want them to fail 2 and with a combination of something else, like maybe a thyroid medication or such. So they're all a little bit different there. So the approval process for TMS and Spravato through insurance companies can take 30 to 60 days. Ketamine is, we do accept insurance for that. They don't cover the ketamine piece, but they do cover all of the infusion aspects and the psychosocial aspects that we do cover there. So that is something that we're aggressively working on. And, you know, it will get there eventually, but it's the double blind study that they really want to see, which is slightly unethical in my head when you're looking at suicidality. So, you know, we're working on trying to optimize that request as well. So we have that. And then, you know, the other piece that we have is we also have vitamin infusions. So when you have these individuals who may have OCD does really well with ketamine too, but they may have OCD, they may have an eating disorder. They may have had gastric bypass. A lot of those individuals get so vitamin deficient, they start having neurologic behavioral symptoms. So while a lot of people don't believe in vitamin infusions, I'll tell you, I was the one, for some reason, I believed in oral consumption of vitamins, but I didn't think the IV was, you know, actually good. You know, it's 100% bioavailable. Yes, it's water soluble, but the nice thing is it hits such high peak plasma levels once you get them that it stimulates over 800 enzymatic processes that last for 4 to 6 weeks. So, you know, a lot of people will say, oh, it's expensive urine or whatever else. No, it actually goes in, turns on the light switch to where you start seeing results 4 to 6 weeks later. Sometimes you'll see acute results, yes, but then you start seeing more results to where people's hair starts coming in better, their skin looks better, they're sleeping better, they're going to the gym more. And we see this with athletes, with first responders. We see this with people who've had gastric bypass. The youngest that we've actually had for a vitamin was, he was 8 when he came, and he had eosinophilic esophagitis, which is a huge, horrible autoimmune condition. And he came to us, sunken eyes, you know, was getting ready to have a flare. Mom could sense it. He'd been to the hospital like 8 times in the past 3 months because where his esophagus felt like it was sloughing off, he felt like he was choking at 8 years of age. So as long as they're greater than 90 pounds, they can have a vitamin infusion. So with him, when he was 8, we did a modified. So we did half dose of what he was supposed to be recommended for. He came back in 6 months for another infusion because he had had 0 flares after that one infusion. So he was off his steroids, he was off the immunosuppressants, all these different pieces, and he'd worked with his pediatric gastroenterologist to help with that. So that's something too, if you're looking at these autoimmune conditions, there's something going on there too, to where is it a deficit of some sort? So specifically looking at pain, you can look at vitamin C, and you can see how vitamin C helps to repair ligaments and tendons and such. So that's a different piece that's also not nearly as invasive as getting on narcotics or going to the streets for drugs or getting a nerve stimulator in your back. These are all things that, you know, we can consider with individuals that are referred to us. So here, future of ketamine, you know, we talked about this a little bit too with ALS specifically, is really a neat thing that's going on. Alzheimer's, there's a lot of really neat studies with psychedelics and Alzheimer's to where they're actually reversing the plaques in the brain, which is super exciting. But Huntington's, ADD, ADHD, OCD, really what we're seeing, like I said earlier, is there's probably about 38 conditions that originate from the brain that ketamine's having some type of effect on. It's just going to be the fact of, you know, is it a comprehensive provider who looks at all the multitudes of and is able to assess everything to try to make sure that you're progressing instead of digressing in behaviors. So so there's all of Matt's wonderful references because he's extremely smart. But one thing too that I'll mention is, so when anyone wants to refer to us, like I said, our providers are very, if providers want to have a direct contact of a provider, we're absolutely okay with that, to speak provider to provider. We would encourage that actually, because we just like to make sure that people are updated. But then also, you know, what we like to do is go from least invasive to most invasive. So if you're looking at somebody who has suicidality, pretty acute suicidality that you're really worried about, while Spravato is FDA approved for depression and suicidality, it's going to take about 3 weeks to see those optimal results for someone. So if they're if you're worried about their acute situation, Ketamine is one of those things to where it typically there's studies out there that state that it breaks suicidality on the first infusion about 98% of the time. And that's something that we've commonly seen as well. So instead of looking at the Spravato piece, a little bit Spravato versus ketamine, right? Your S isomer of Spravato is your longer acting. Ketamine, you've got both there. You got, to where you got the robust action. You also have the longer term effect. Ketamine, when we give it IV, it's 100% bioavailable. It actually crosses the blood-brain barrier. It has a direct effect. Spravato is a little bit different. Now, Spravato is 0 to 44% absorbed. They're still trying to look at that vascularity aspect as to why the absorption rate does vary that much. So they're looking at that. It does take about 3 weeks. They typically recommend 20. The induction periods, they recommend 20 appointments over the course of 3 months. And that's great for individuals who really have a hard time getting up, getting motivated. They may need an environment to where they can connect with, which we do have a very connecting environment, very spa-like environment, what we look like or what we look at each Revitalist clinic. But Spravato, if you're looking for acute suicidality breaking, I would strongly encourage that you would look at ketamine with that piece, just because of the rapid changes and the known difference in bioavailability. But typically what we would recommend is we would recommend the least invasive first, especially if they met entrance aspects with the major depressive disorder and failing of 4 antidepressants. So we would typically look at TMS first. Secondarily, we would look at ketamine, more so for the proactive synergistic abilities to cause the neurogenesis and the increase the plasticity. So we'd want to try to look at TMS first, then ketamine. And then the third line would be to look at ECT therapy. So a lot of people will jump to ECT first, and then they'll go to ketamine, and they'll go to TMS. So we're kind of different to where we try to go to least invasive to ketamine to most invasive, which would be the repetitive general anesthetics that you receive also with ECT therapy. So that's something to consider as well. But I think that's all. Matt, do you have anything you want to add?
Just one quick thing that in addition to all the mechanisms of action with ketamine that we talked about and all the benefits that you talked about with the vitamins, a lot of the neurodegenerative disorders and a lot of disorders in general, but specifically the neurodegenerative disorders, it all starts with oxidative stress on the cellular level from overusage of those cells, which then sets up a chronic inflammation process. And one of the other things that we offer are antioxidants, which they have been shown in research to augment the effects of other mental health therapies, because it decreases the inflammation of those signal processing pathways in the brain.
So if you have questions, this is our primary address here in Knoxville, the corporate headquarters, but we do have 10 locations across 7 states. So if there's questions, you can always email us. Mine is Kathryn Walker at Revitalist.com. You can find me pretty much anywhere associated with Revitalist. Matt will soon be the same way, or you can email Matt Dolan at Revitalist.com. Or the easiest part, I would say, would just be to go to the website. We do have the referrals on each website, each location, to where you can refer for TMS, ketamine, or Spravato. So that's, there's direct forms there to help with that. And we're also happy to, if someone needs more education, staff, if staff need more education from this aspect, we're happy to come and to help explain it more on a nursing level, because Matt and I also do keep our RN license up as well, so we can understand kind of that piece as well. So appreciate your all's time today. And then if you have any questions, always reach out, and good luck and stay healthy.